exam from the midterm. So I'm either going to have a possibility as the ear, the nose, throat, or the eye. Pretty straightforward. Okay. So we'll start off with that. We don't have to worry about the skin. And then you go straight into the pulmonary exam. Hi, my name is Margaret Johnson, and we like the dark.
Yeah, apparently you guys didn't pay the
Yes,
electrical.
exactly. Yes. I put on my special X-ray vision glasses so we could do the whole exam.
In the dark,
Okay. Now, as I talk to Mr. Julian, I'm noticing that he's not in any respiratory distress. That's an important. So there's no respiratory distress. Right. But he does have a good sense of humor. Now, the other thing that I'm noticing is that his IE ratio, inspiratory to expiratory ratio, is 1:2, and he really is eupnic. Now, does everybody know what I mean by eupnic? EU means normal. Now, as I walk, I'm estimating his AP transverse diameter, and it is 1:2. Now, just for filming purposes, could you put your knees over here, please? And then all the photographers can come right here. Good. All right. Now, inspection first. Now, I don't see any obvious deformities such as scoliosis. Now, at this point, I'm going to do some palpation. Now, I palpate the cervical spine for tenderness, the thoracic spine, and this is what I want you to tell me, the lumbar spine, and then I check for sacral edema, and there is none. Now, I also do CVA tenderness as part of this exam, but for right now, I'm just going to check out the symmetric excursion of the chest. Could you inhale, please? And exhale. So there's no tenderness, and we have symmetric chest excursion. Now I'm going to percuss when I'm finished with palpation. Now, say 99.
99.
This is fremitus.
99.
Now, I would expect that over the big airways,
99.
fremitus will be increased,
99.
and over the small airways and the alveoli, go ahead, 99. The alveoli being smaller will have decreased fremitus. So fremitus increases over the right and left main stem, and it decreases in the periphery. So that's right on the money. Okay, now we're ready for percussion. Okie doke. Now please look at what I'm doing. Now we get the apices first, and notice I'm not on bone. Then I find the vertebra prominens, and I'm going to go side to side. Okay, now he is definitely resonant to percussion. Now will you inhale and hold it? Exhale and hold it. Did you hear the dullness? Mm-hmm. Okay, now you can breathe normally. Now his diaphragmatic excursion is from 3 to 5 centimeters, and so you can all see that that's normal. Now we expect that the lung will not descend as far on the right as on the left because of the liver. So what we've done is we have percussed and he's resonant. Now I'm ready to listen. So take some deep breaths through your mouth with the mouth open, please. So these are vesicular sounds, ratio 3 to 1. These are bronchovesicular sounds, ratio 1 to 1. Vesicular sounds, here at the bases, ratio 3 to 1. Now, could you say E for me, please?
E.
Again?
E.
Keep on saying it.
E.
Okay, more time.
E.
And then finally.
E.
So there's no E to A change. So I prefer that you do that particular sound for evaluation of voice sounds. So what we did is we did inspection, palpation, percussion, and auscultation, and that's all there is. Julian, could you please lie down supine? just going to check for tenderness. We're not going to do this on the ladies. Let me know if you have any tenderness. So there's no tenderness. Okay. Now in terms of breath sounds, I'm just going to listen for the vesicular and also the bronchofascicular sounds. So could you open your mouth and breathe? Okay, so vesicular sounds in the apices. Now remember, I'm above the clavicles. Now I'm going to go to the second intercostal space where I hear the right main stem and left main stem. Now here I hear bronchofascicular sounds, ratio 1 to 1. Okay, again. And now I'm hearing vesicular sounds again. And I'm really going to listen to this right middle lobe. Now the ladies, we're just going to have to skip it. Now for ladies in real practice, you have them lift up the breast like that so you can listen to the right middle lobe. Now at this point I'm going to do cardiac. Now of course beneath the gray skin I can't honestly see, but in your partner in our exam you probably will be able to see the point of maximal impulse, especially on a man. And I would expect it to be medial to the midclavicular line of the fifth intercostal space. Now, here comes the important part. I want you to palpate the places you're going to auscultate. So, okay, so you feel a light palpation at the mitral area, the tricuspid area, the herbs area, pulmonic, as well as aortic. Now, I don't feel a thrill, which would be a vibration, like 99, and that would connote that you've got probably a 4 out of 6, even 5 or 6 out of 6 murmur in terms of loudness. Now you're going to take your stethoscope and you're going to do your normal survey. So we'll start at the mitral area. So what you need to tell me is that S1 is greater than S2 at the mitral area, same as the tricuspid area and the herbs area. Now when you get to the pulmonic area, please tell me that S2 is louder than S1, and you move over to the aortic area. Now we're going to flip the stethoscope or use the bell function to pick up S3, S4. So retrack the path you took, and I'll give you a chance for an extra point. If you can tell me the cadence, which is dut, 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 or dut, dut, dut of S3 and S4, and what causes it. Fair enough? But I'll choose S3 or S4. Now, let's say I had trouble listening to my S3 or S4. The left lateral sideline position is the best. Now, I'm not going to do this to Julian because I may roll him off the table. I value you. But that would be another maneuver to bring the heart right up to the chest wall. Now I'm ready to do the abdomen. Now this is what I'm going to focus on. Positioning of the patient. Now could you hand me one of those little paper gowns there? I mean, this is like nothing, but we really do have to address the issues surrounding flexion of the neck. Now, okay, go ahead. You can put your foot down. Now I want the legs bent slightly. There we go. Now, first of all, I'm going to do my inspection. May I? Thank you. Okay, now the abdomen is rounded. I see a surgical scar in the right lower quad. And what you would do is measure it so that's 1, 2, 3, 4, 5, 6, and 6.5. Yeah, that's about 6.5 centimeters. I see the aortic pulsation. I don't see any asymmetry or obvious masses or other surgical scars. Okay. Put my ears on, and I'm going to listen here at the ileocecal valve. And of course, bowel sounds are present, right? And we're not going to be here 5 minutes. Now, normally you'd listen all over, but for us, we know. Where you're listening for vascular sounds is important. Now, if you can get these landmarks, take the costochondral border right here and use that to draw a line, and use the belly button to draw a line. Make the midclavicular lines continue through, and you can locate the renal arteries. Now if you draw a line here and you use the top of the ischial spines as your other parallel line, the iliacs are right there. So the 5 places that I want you to verbalize that you're going to listen will be the aorta, the renal arteries, and this is with the bell, of course, the iliac arteries, and then the femorals. Now, this is a perfect position to actually palpate the femoral artery, and it should be a +3 out of 4. Now, light palpation doesn't go very deeply, it's a one-handed. Now, are you ticklish? Just a little bit. I kind of noticed that little flinch. Okay. Now, deep palpation's deeper. So that's more of a swimming movement. Now, I feel the rectus abdominis, and I can't tell you how many nurses get fooled by that. And patients think that they're falling apart. Okay, now, let me show you the 2 ways to palpate the liver. Now, before I do anything, I just wanted you to think about what I'm saying. When he inhales, what's going to happen to the liver? It's going to come down, right? And when he exhales, it's going to go up. Now, if somebody was examining you, wouldn't you want them to stick their fingers in when your liver was up, not down? I just want you to think about that. We can try it out. You'll be very sure of your answer. Now, Julian, will you breathe in, inhale, breathe out. Now he's making a little hole for my fingers, look at those. Inhale and hold it. Now he's bringing the liver down to me. See, that's what we want. Now, if he suddenly did something like this, with my fingers underneath his rib cage, that tells us that he has inspiratory arrest, or Murphy's sign. Now, liver hook, same thing. Inhale, exhale. Now, hole, little hole, fingers go in, inhale, and hold it. Not bad. Now, since there's nothing here, no solid mass, it's just bags of tissue, it's a little bit different here. Inhale, exhale, so you can go in farther. Inhale, and hold it, please. Thank you. Good for you. All right, now let us try to percuss. Now, first of all, get the generalized note. What's that?
Timpani.
It's really a pretty nice tympanic note. Now, he's been working on his abdominal muscles, which is good. Congratulations, it works. Also, he doesn't like getting beaten up. Now, let's do exactly what the film said. Let's start up at the lungs. Now, since you've all gotten really good at finding the 5th intercostal space, we know that the diaphragm is right below, because it starts at the 6th rib. So, now that sounds resonant to me. How about you? How about this one? Okay.
Chest.
Now that's gut. That's gut. That's dull. 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 Ah, so it turns out that that's lung and that's the span of the liver. Now, we know that it's 6 to 12 centimeters. So let's measure this. Could someone hand me the little Jaeger chart? That has one, great. Now, I'm guessing that we've got about 7.5,
4.
maybe 8. Margarita, not bad. 8. Good. Now, let's do the spleen. Not required, but let's do it. Now, could you move over this way? Thanks very much. All right, now if you pray, your hand over your hip. Good. Now, the ribs go this way on the side. Now, let's see what you think. That's the stomach. Did you hear the difference?
Mm-hmm.
Okay, that's your spleen, right there. Let's do that again. Okay, there's your spleen right there. Ha! Okay, now that's your abdominal exam. How hard is that?